until I moved out to West Virginia. I was the third dentist ever in the history of the American Cancer Society to get one of their career development awards. And that allowed me to spend time at the Mayo Clinic studying bone diseases, and also allowed me to take a fellowship at the College of Dentistry in Copenhagen, Denmark. So that allowed me a very unique experience, and the bone pathology really came to fruition in West Virginia because one of the two sort of founding fathers of this whole cavitational concept is Dr. Alexander Roberts. He's an oral surgeon who happens to live about 45 minutes down the freeway from my town. And I'll give you a little bit of my personal history relative to this disease after I simply say that I was the chairman of Oral Path at WVU for about 17 or 18 years, and only left that school as it started to go downhill in quality, and we got a new dean I just couldn't get along with. I decided to go into private practice, try to set up an oral path biopsy service in West Virginia. Keep in mind, this is a town of 28,000 people, Morgantown. There's not a lot of business locally. But as it turns out, except for one other person, I'm the oral pathologist who has given more CE talks than I think any other. And that has been a way to build my biopsy service. So the service now is part of my center, and we attract tissue from 44 different states and 5 countries. It is probably in the top 10 or 12 oral path biopsy services in terms of size. But one of the neatest things about it is this particular disease. I definitely get more bone disease and bone tissue than any other oral pathologist. And it has allowed me to create an inflammatory bone registry, tissue registry in my center. And that has been the basis of a great deal of research. Much of it has not been published yet. But right now we have over 5,000 samples of tissue sent to us with the surgeon's diagnosis of osteonecrosis, osteomyelitis, osteitis, those kinds of inflammatory bone changes. If anybody wants the handout to sort of get an overview, I will give a copy or a couple of copies to Ed also. And you can get that, as I mentioned, either downloaded off my website or call our center, and we'll send that out. I didn't want to be the director of a center. Even though it's been very successful, it really is something that I had to talk somebody else into being the director of. I've misspelled his hometown. He's just north of here. But he is the director, and he kind of oversees things. I'm only the director of research for the center itself, and that's the way I prefer to have things. Morgantown is the home of West Virginia University, and you might see just a little bit of an above-ground rail here with a station. There are about 7 stations. We call that the PRT, the Personal Rapid Transit System. It was created in the early 1970s, one of Senator Byrd's pork barrel projects, it's been called. But it was really the first above-ground individual car computerized transport system in the world. And it's still in perfect working condition today. It's one of the unique features of our town. The medical center is the medical center for West Virginia. It's primary, secondary, tertiary, whatever kind of care possible. It's very difficult, as you can imagine, to keep all of this funded in a state as poor as West Virginia. And so the physicians and dentists of the university got together and formed a corporation to build the new hospital. The old hospital was becoming just too outdated. So this is run by the university, and the land is leased from the university, but it's a private hospital called the University Hospital. And of course, West Virginia, the reason I love it is because of the mountains and the streams everywhere. We do, however, have a reputation once you leave the state borders for having lots of people like this, and believe it or not, We now know how many hillbillies there are in West Virginia. They were counted last year or the year before, and we have like 32,000 out of our 2 million residents who don't really live a bad life, but they're very, very poor. When I was here last, I probably mentioned our textbook. This is one of the standard textbooks of oral pathology. It's published by Saunders, and it has I think about 2 pages about NICO in this textbook. I put it up here really to, it's also, by the way, a textbook that has in 4 years sold about over 20,000 copies, which is a huge success in the dental textbook business. It's not maybe what George Meinig has sold, but he's sort of in the popular press. But at any rate, this disease is now in 10 standard textbooks in dentistry and medicine. It might be just a sentence or two that's mentioned. The American Academy of Orofacial, or what is it, Oral Head and Maxillofacial Head and Neck Pain. Quintessence International publishes their textbook, which is really a sort of a cookbook classification for facial pain. And the new editor for the next edition has asked me to give him about 15 manuscript pages about NICO, so that will be in that textbook as well. But I don't want to fool anybody. There's still a fair amount of controversy. It seems to be in pockets around the country, and I do my best to convince other oral pathologists that it's real, but sometimes it doesn't work very well. Well, when I got first involved in this disease, I was thinking it was an infection, as many of you felt. That's where I got my information, and everybody else thought it was an infection. And I probably signed out the first 1,500 cases at least, maybe 2,000, as chronic osteomyelitis. I was showing these microscopic samples to literally everybody I knew. And oral path is quite a small community. We all know each other fairly well. And only one person in the entire country had even a hint of what this was. And he suggested perhaps it was an ischemic damage rather than an infection. And so I shifted over just before I gave my first talk on the disease. I shifted the name from osteomyelitis to osteonecrosis, like literally the week before. And I presented that talk in Ireland under this name. And I like the name, but now the name itself was created to kind of avoid the controversy that Ratner's cavities and Ratner's cysts had about it. But now NICO, of course, is the controversial name. And it's been a very interesting process over the past 10 years, watching how other people react to this disease. I like this name for 2 reasons. Number one, it points out the 2 major unique features of this disease. It produces pain which is diagnosed by others. I don't diagnose these neuralgias, but diagnosed by others as neuralgia or neuralgia-like. I kind of use the line of reasoning that these are not real trigeminal neuralgia or atypical facial neuralgia cases. These mimic those particular diseases. Other people are less restricted, I guess, in their talking, and I have heard physicians, for example, come right out and say every case of atypical facial pain or atypical facial neuralgia is this disease. But I've never made that statement. I have tried to find out how many people with atypical facial pain have this disease, and it's just not, not a doable thing at this stage. We have no idea. But that is one of the most unique forms of or aspects of this disease, and the fact that it produces hollow spaces. You perhaps aren't aware of this. The term cavitation is something that's kind of commonly used for this disease. But the cavitation itself is nothing. It doesn't produce any disease whatsoever. It is a hole. It's air. It cannot do anything but be there. But it is evidence for a very unique disease process in that bone, and not only unique, but we're finding much more commonly. We're finding it much more commonly than we imagine. There are only 2 diseases capable of producing a hollow space within bone. They both have to do with ischemia. In the jaws, one of these we call traumatic bone cyst. Unicameral bone cyst is another name that's used when it's found in the long bone. The surgeon goes in and finds this empty air-filled space. The other disease is osteonecrosis. So if you have a hole in somebody's jaw and you indicate that to the pathologist can only give you one of two diagnoses. There are no other options. How do I know this? Number one, very extensive review of the literature, but number two, in December I spent a whole week in Manhattan, and for somebody who's been in West Virginia as long as I am to spend a week in Manhattan, you can imagine how much trauma that would be. No, it actually wasn't bad. My high school days were spent in New Jersey, and that was when Greenwich Village was really hot, and so it was kind of a fun thing. But the reason I went there is they have the largest bone hospital in the country. It's a 7-story building called the New York Hospital for Special Surgery. They do nothing but bone. More bone surgery than the Mayo Clinic, which would come in second for bone treatment. And the head of pathology just happens to be the guy I consider to be the national expert on osteonecrosis. I had sent him cases of Nico earlier. This time I brought, 3 or 4 dozen cases up, and we sat down over a multi-headed microscope, and I showed him what I was looking at, and he said yay or nay to my interpretation of these things. And we also were very fortunate, I was very fortunate, in that one of the experts from Japan, osteonecrosis is a really hot disease in Japan as far as research. There was a Japanese pathologist there spending a 2-year fellowship, in the second year of his 2-year fellowship. And so I had his expertise also, and he looked at my cases. And the end result, I guess at the end of the day, was that they definitely agreed, as I knew they would because I had previously sent cases. They gave me, it was wonderful, because the words I use in my descriptions, they knew. And there are many unique descriptions in the literature of osteonecrosis, in the pathology of osteonecrosis, that are not found in other diseases. So when I say these words, even my own oral path colleagues have difficulty knowing what I'm talking about. So we did run into, the main reason I did this was I have, in the past year, made a discovery. I took 1,000 cases from the bone registry that I have because I had the impression that most of the cases of osteonecrosis are not full-blown disease the way we find it in the hip. It's more mild disease, not in terms of pain or symptoms, but in terms of what we see under the microscope. And there is a new disease. It has 2 names. One is transient ischemic osteoporosis. I like the other name, bone marrow edema, and I'll get into this in a little bit. But both of these diseases are diseases very strongly associated with increased pressure in the bone. They may not produce any dead bone at all. So keep that in mind. We have a disease, osteonecrosis, that was until fairly recently considered to be diagnosed only from dead bone. The osteocytes just aren't in the bone. That's how we say that it's dead. But now we're finding, I found in those 1,000 cases, I just presented it in South Africa a couple of months back, but I found that something over 2/3 of the cases of Nico were in fact this bone marrow edema, or transient ischemic osteoporosis. This is a disease that's very regional in nature. It comes and goes. In long bones, since getting to the bones is a bit of a problem, many people are simply left alone. They're taken off steroids, which is a cause of this disease. They're taken off estrogen, which is a cause of this disease. They're taken off, chemotherapy is another cause, pregnancy is another cause. There are a variety of causes, including smoking and alcoholism, alcohol abuse, that are tied to that particular disease. And this is a major breakthrough, to know that it explains, at least in my mind, why I can show a tissue sample, and I'll show you some in a little bit, of Nico to a friend. And he will say this is normal bone marrow. And I will send it off to an osteonecrosis expert, and they always say this is a variation of osteonecrosis. And that's probably what the bone marrow edema syndrome is. It's a variation of osteonecrosis. So in the past year, there have been that particular major change in this disease. The other major change is a disappointment. We published a paper in early 1998 out of the University of Cincinnati about these coagulation disorders we've been finding in this disease. And that paper essentially said, and I'll get into this in more detail also, but it said about half, 40 to 50% of our patients, these are severe NECO patients, severe pain patients, have dramatic or considerable diminution of pain just using anticoagulants. And we thought that this was going to be the answer for some patients, but it turns out we're still using it, but too many people are getting side effects. Too many people, the pain comes back after their body somehow adjusts to the use of the anticoagulant. So it's not turning out to be the promising therapy that we had hoped. But as time goes on, perhaps we can refine that. I'm totally out of that loop. I just make the diagnosis, and the hematologists are the ones taking care of those patients. There's been a lot of humor in this disease. There's been a lot of sadness also associated with legal problems. I probably won't get into that too much, but I can say that I'm kind of the person that's called in to be the expert witness to help the fellows who send their tissue off and are being harassed by state boards for this disease, treating this disease. And I probably know all the osteonecrosis, jaw osteonecrosis legal cases in this country. And we're winning almost all of those, almost all of them. Within the last year, 2 more, the last 12-month period, 2 more cases were won in California and in Arizona. One of the problems that is for somebody who says that this disease doesn't exist is they've waited too long. There are way too many papers from too many people. I'm just one voice in this wilderness, but there's just too much science now behind it for anybody to say no. It is a disease of ischemia. Is it an infection? If you culture these, you will culture bacteria, a mixture of bacteria, in most cases, the majority of them. Ratner was saying 100%, Roberts was saying 80%, but very few people have cultured, and the reason is that the cultures produce normal oral flora. I have to believe that there is a bacterial or a microbiological component to this disease. Is it the cause of the disease? Only sort of in a bouncy ball fashion. I think that there has to be susceptibility in the bone. There has to be a patient who has a problem of poor blood flow to begin with. And this is maybe not a problem in soft tissue, but the unique environment of the bone marrow makes it a real problem, and probably a fairly common problem in the bones of the human body. Well, we know, and you'll know in a little bit when I show you a slide, and you'll get it from the handout as well or the website. We're up now over 80% of NECO cases sent for coagulation disorders have coagulation disorders. Most of these are hereditary in nature. They probably had the problem from childhood, and something happened as they started to get older. Their blood flow wasn't as nice and fast and clean as it was when they were younger people, and sometime in middle age, these problems crop up. The problems that can trigger a painful event or a NECO event, if you want to use that terminology, I like the idea of triggering event, have to do with dentistry a lot. You work on a crown, somebody within a day or maybe 2 weeks later starts getting this deep ache, and they have it becoming more and more intense for the rest of their lives. Another thing is infection. Any infection is going to change the coagulation state, not just in that local focal area, but throughout the body. It will certainly, the coagulation will be more concentrated, or enhanced coagulation will be more enhanced locally. It's just natural. That's what normal inflammatory responses do. It has been only fairly recently, though, that we've known about the systemic effects of a focal infection. And I use the term focal infection in a much more broad spectrum, just a localized focus of microorganisms. And in this particular state, there are some interesting papers out there. 2 years ago, a study of infections, focal infections associated with stroke. It actually was a study of a whole bunch of different parameters. It was published in the journal Stroke. And their conclusion was, of all the different parameters that might, or risk factors that might lead to stroke, the number one parameter was a focus of acute infection within 30 days of the stroke. Where were these infections? They could be anywhere in the body, but about 2/3 of them were in the maxillofacial region. They were either dental infections or sinus infections or tonsil infections. And why did this lead to stroke? There were no bacteria found in the brains. It was because of the enhanced coagulation. And within 6 months of the publication of that paper, another paper found that same correlation. Somebody with a focal infection gets strokes, or gets a stroke. But in this case, they specifically looked at one clotting disorder, and they discovered that the people with the clotting disorder, that was a group of people that were getting the strokes. So now we have an intermediate step, and it's a major step. It seems to be not only the cause of these bone changes, but perhaps the major cause of stroke, and perhaps the major cause of coronary artery disease. Why do I say the latter? Because there is a disease called homocystinemia. And homocystinemia is a coagulation state. There are three tests for that particular hypercoagulation state. And if you read the cardiovascular literature now, you will find some papers within the past 2 to 3 years that state that homocystinemia is more significant to coronary artery disease than cholesterol levels or fatty acid levels. This is all in flux now, so I'm not making any firm statements, but I think it's really, really exciting, and it makes sense. Somebody can have cholesterol, smoking, all of the other features that lead to coronary disease, but the coagulation state is sort of the mechanism that leads to the thrombus, the clot that actually causes the infarction. Does this go on in the bone? Well, the disease in the jaw is the same exact disease as in the hip, and I'll go through some of this hip disease in a moment. But the disease in the hip in the 1960s was called coronary disease of the hip because of the infarction and the ischemic state in the bone. That was just sort of a catchphrase used in the literature for this disease in the hip. And that is, in fact, what happens. It's kind of exciting. We don't have this data for the jaws, but in the long bones, within the past year, they have discovered that it is a problem primarily, 85+% of the cases, of the bone not being able to get out of the blood not being able to get out of the bone properly. Obviously, if there's an arterial problem and there's no blood going into the bone, that could lead to the same problem. And the second feature that seems to make sense there is it probably is these tiny clots. The coagulation states that we're talking about in osteonecrosis of the bone seem to be that group of patients that they don't have a real serious problem, but because but they have enough of a hypercoagulable state that they are able to constantly be creating microclots. And these microclots just zip through the big veins and the arteries, but they can get caught in capillaries. And the capillary bed is not allowing, there's sort of a sluggish flow through capillary beds that might explain much of this. That's theory at this stage, but I think it's got some good thinking behind it. Well, The other thing that happens, now that we know that this is an outflow problem, we have an explanation for this other. There is an intramedullary pressure, the fluid pressure as well outside the blood vessels as well as inside the blood vessels is tremendously high. In normal bone, in your bones, assuming you've got normal bones, the pressure in those bones is somewhere at least twice what it is in the rest of your body, in the soft tissues, and it's not unusual to find it 3 and 4 times higher. We're talking about perhaps 60 milligrams of mercury, if I can mention mercury in a good way here, as opposed to maybe 10 or 12 or 15 milligrams for soft tissue. That's normal. That's a normal state. So the bone marrow, that environment is already under a huge amount of pressure. Why? Who knows? But that is one of the unique features of bone marrow. In ischemia, even the mild cases called bone marrow edema, that already high pressure can go up another 4 and 5 times and routinely doubles from the normal pressure inside bone. So what happens if you get those kinds of pressures and you have a venous system that is made up of the thinnest veins in the whole body? They have to be thin and they have to be porous because the white cells have to pop into those veins, and sinusoids, sort of variation of the veins. They have to be able to pop into the lumina of those vessels in order to get to wherever they are required. The infections, for most of us, are not in the bone marrow, they're somewhere else, and so those white cells have to travel. Well, so they're very thin veins, they're very weak veins because of that, and now we are increasing the outer pressure. This doesn't happen instantly, it happens maybe over months or years. And as that pressure increases, we've already got an outflow problem, but now the pressure is collapsing the veins. The venous system goes into collapse, and at that stage we are getting into perhaps a disease state rather than just a damaged marrow state. It is the kind of thing that also explains why in some of your patients you've opened into an echolesion or cavitation and they feel instant relief, just like opening into a pus-filled tooth, instant relief, because there are pressures, sometimes gaseous pressures, gangrenous pressures from the dead tissue, but usually it's fluid pressure. And it also helps to explain why some of your patients feel really bad one day and the next day they're fine. I have several patients, I'm trying to correlate the air pressure with what goes on inside, or what goes on with their pain. If it is a fluid pressure phenomenon, it makes sense that it would vary with outside pressure. The differential between the inside and outside of the bone would change on a daily or maybe hourly basis. But there are other explanations for that kind of thing. But I think it's important to keep in mind that we have just lousy blood flow going through these bones, and there are a variety of reasons. There is a textbook that just came out that lists over 60 different causes of osteonecrosis. A lot of them are systemic diseases, and we just don't know which comes first, whether the clotting coagulation problem that cause the bone disease is maybe important in the other diseases such as lupus, or whether the bone disease is releasing some material or toxins that is producing the other diseases. I mean, it's tempting to think of it as the jawbone as being the main problem area. But quite frankly, when I look at the tissue in the jaw, it looks exactly the same as the tissue in the hip and in the knee, in the fingers, and every other bone in the body, and those bones do not have bacteria. They have cultured those forever, and they do anaerobe cultures. I mean, these are hospital cases, and they can do those things. But the same disease elsewhere in the body, but no bacteria elsewhere. And that makes me think that the bacteria are, in the jaw cases, are a secondary phenomenon. This is poor blood flow. Therefore, if there is an infection that happens to get into this jaw, the jaw is not capable of responding properly and getting rid of it. Speaking against that particular argument is the fact that we don't find pus at all, or hardly ever, in an echo case. And if this is such bad bone, why don't we get that pus? Why don't we get fistulae blowing out through the cortex? It just doesn't happen. And it doesn't happen in the other bones either. The bacteria are there, and they're obviously producing toxins. Boyd-Haley has shown that very nicely. But there's more to it, and we're just, I think, in the early stages of trying to understand this whole thing. Microscopically, we find old and new infarcts in this tissue, and that simply shows us that this is a long-term process. Some people have a massive infarction, just like a massive heart attack can occur. It's just one big, massive heart attack with no real precursor sign or symptom. But most people with this disease in the bone have little infarcts. Microinfarctions are called. And they just kind of coalesce. You get enough of them so that you get damaged fibrous tissue and you don't have a lot of marrow left. But it is definitely a disease that is of a chronic nature. And look at what we're dealing with in the jaws. The cavitations that are found are usually found in the third molar site, over half of them now. Whether it's a pain group or a non-pain group, over half of them are the retromolar pad area and the tuberosity area. And the third molars just anterior to those. Well, most of those are removed when people are fairly young. Now that we know that the coagulation disorders in this disease are disorders that are hereditary, and these are probably, they had to have been there since childhood days, it does explain a little bit about why we would have hollow spaces in a socket, for example, instead of healing properly. Holes in hollow spaces in bone are not a normal state at all. Whether they are capable of doing more than just being a hollow space depends on the bone that's around them and the cause of that particular state. But I think we have to assume if you have somebody who's 50 years old now, whether they have pain or not, you can see something strange on an x-ray or some other means, by some other means you find an area that you are suspicious enough of to go in and do surgery. If you find that hollow space, I believe that you have to conclude it was hollow from the day it was extracted. I mean, it was just an example of poor healing. And poor healing, ischemia is a good reason for poor healing, just as low-grade infection is a good reason for poor healing. We don't have the main reason for poor healing in long bones, and that is just poor apposition and movement, too much movement of the bone, the ends of the bone. We don't really have that as an explanation. So we only have ischemia and low-grade infection to explain these sockets that are found. Also, this is a disease that microscopically as well as clinically produces very poor, or at least hard to see, inflammatory responses. I have all kinds of examples of dead fat, liquefied fat in my tissue samples, and there isn't a lymphocyte next to it. There isn't a neutrophil next to it. There is no pus at all. And liquefied fat is a pretty toxic material. If you put your own fat and put a little bit in a blender and injected it back into your skin, you'd have quite a reaction there. And in this disease, we just don't have a reaction. And it doesn't make a difference whether it's a jaw case or a knee case or a hip case. Why is that? It's a mystery. A complete mystery. One of the reasons that perhaps seems to make the most sense is a suggestion of Boyd-Haley's, I think last year or the year before. And he said that the neurotoxins that he's been finding in Nico lesions, and they're all very high levels of neurotoxins, they all have that. He thinks that they're so high that they're actually preventing the white cells from chemotactically moving into an area. They're putting up roadblocks all around the area. And that may or may not be the case. We just don't have an explanation. But it is true that there's poor healing and poor inflammatory response. And as you know, when I first got into this and made up the name, everybody I had run into with this disease, and it was over 300 cases at that point, had pain, huge pain, neuralgia type of pain. Now that I've got a wider group of people sending, I would say probably just under 90% of the patients have pain. The rest have no pain. And I know many of you are doing biopsies or treating this without doing a biopsy. And I think most of those patients are people without pain. Can you have pain with, or can you have this disease without pain in other bones? Absolutely. As a matter of fact, it's not unusual for somebody with this disease in their hip to be walking along and all of a sudden feel this instant pain because their hip just collapsed. The disease goes on to the point where it collapses from this mushy marrow. There's no support there, of course. And I mean, that must have been going on for many months, perhaps years, in those individuals. So pain is not a real sign of, while it's a characteristic of most cases of this disease, it's not a real sign that helps us to determine whether somebody's got a severe case or not a severe case. This I like. The best place to look for this disease is in the rheumatology textbooks. The bone pathology textbooks are usually tumor textbooks. But the rheumatologists deal with other things, and this is becoming one of their most common diseases. Osteonecrosis now accounts for 1 out of every 4 hip replacements in the United States. 20 years ago, it hardly counted at all. Has there been a huge increase in this disease? No, it's just that pathologists are now seeing things that they didn't see before, and instead of calling something arthritis, they look in the marrow and see that it's bone marrow edema or osteonecrosis. And as a matter of fact, there are many cases of osteonecrosis of the hip that have arthritic changes above them. But this, I think, is really key. These include a heightened clinical awareness. Nobody is ever going to make this diagnosis if they don't think about it. It's not that obvious on x-rays. I have friends who only see it maybe 10% of the time, people who treat this with some degree of frequency. I can see it much more than that, certainly over 50%, probably closer to 75% of the time. On routine periapical films, I can see something. It's not a diagnosis, but it's something abnormal in that site. But I use a darkroom, I use a magnifying glass, I do things that I was taught to do as a dental student and didn't do until this disease came along. But good quality radiographs are very important. It turns out that bone scans, routine bone scans, are extremely important. In the round balls on the ends of the long bones, MRI is very good at picking this up, but it doesn't seem to be so helpful yet for the irregular bone to the jaw. And this is also a very key feature. I've just touched on it a little bit, but initially the patient is asymptomatic and may remain so until well after the condition is diagnosed by imaging. In many instances, however, the patient develops a significant amount of pain before evidence of radiographic imaging. So I told you one side of that story. Somebody can have massive destruction visible on x-rays, MRIs, every other imaging test, and yet they don't have any pain. And then there's the person who has just a tiny, or has a massive amount of pain, I guess, is what I'm trying to say. A huge amount of pain, and there's very little that shows up on the radiographs. This disease, I mentioned this last time because recently the radiologists have come up with a stage 0. I won't show you that chart again. It is in the handout, but stage 0 means that this disease is negative to every imaging technique known to us today. Completely negative. The only way you can diagnose it is to go in and do a biopsy. How do you know that it's even there? Those are the people with the pain. And in the hip, pain usually leads a doc to focus in on the joint and the bone, a bone that makes up that joint. In the jaws, what happens if somebody comes in with pain with fairly normal x-rays? We don't still assume that there's something going on in the bone. We automatically jump to these neuralgias because we've had those names around for well over 100, maybe 200 years now. So it's a bit of a social phenomenon as well. But MRIs, you can see how obvious these things in. When they put a T1 spin on it, we get one picture, and the T2 gives us another picture. And while I'm not very sharp in MRIs, the radiologist can compare these two and say that this is liquefied fat, or this is a fluid. And the fluid state, there are very few things that can produce fluids as well inside bone marrow, and this is the major disease for it. So MRIs are probably, they've become, with computer imaging enhancement, they've become pretty much the standard for diagnosing this disease elsewhere in the body. Now it's just fuzzy because it's a close-up of a... This is really the standard, the second standard. It's a bone scan. It's not the kind of bone scan that you would do if you think of infection. In the early days, I was thinking infection, and so I asked for gallium scans and indium scans and the other scans that put the radioactive isotope onto the white blood cell and then see where the white blood cell goes. I've already said this is a disease without white blood cells, or very few anyway. And that's a mystery to us. We don't know exactly why that's happening, but it is a reality. So all of the tests that normally you would do for identifying an infection in bone are pretty useless here unless there's an unusual secondary infection of a high enough level to produce inflammatory responses. And so the test that we use is the one that really identifies two things: increased blood flow to an area, and the Nico lesions are areas of dryness normally, but there's some blood flow around most of them, trying to heal this in a certain fashion. And so we do end up with hot spots, or black areas of increased uptake. And here we have kind of a generalized hot spot here. And you know, it's very difficult to determine what is good and what is bad with these diseases, or with these types of scans, because it's quite primitive. But I'll show you later on that with computer enhancement, it's becoming much more easy to interpret. Can a dentist ask for these scans? I just write out TEC scan, right and left side of face and anterior face. TEC 99 MDP. You have to have the MDP, and this is also in the handout and on the website. The MDP bone scan looks for that vascularity and also looks for exposed hydroxyapatite crystals. So if bone is being destroyed or created, then this scan will pick it up. And as it turns out, the TEC 99 MDP bone scan is the oldest of the bone scans. It was the original one. It doesn't give a diagnosis. It just tells you there's something there. It could be infection, it could be osteonecrosis, it could be a metastatic disease, but there's something there. We are finding now that the jaw cases are positive in approximately at least 40% of the time. And in a study that I'm doing right now with over 100 cases, it looks like about 70% of the cases will be positive. Do the radiologists read them out as positive? No. After you've told them some things about this disease, they will say so. But the radiologists look at these scans, and if there's a hot spot in the jaw, they just assume it's gum disease, it's periodontal disease. That's what they've been told for generations now. And this is an old scan, this is an old test. So a negative report doesn't really mean very much. You have to look at that scan yourself. And you don't have to have a real hot spot, but if you have just a little increase uptake in the area where the patient has pain, or you see something abnormal on the x-ray, or there's a tender site, then that's just another little bit of information that helps you to decide whether you're going to go in and do surgery on that. Quite frankly, initially I was using this scan for political reasons, because if I had a positive scan, it was much more easy to talk an oral surgeon into going in and doing the work. And I can't tell you what has happened to the histology of this disease. It has just exploded, just like the field of coagulation has exploded. And I have to try to keep up on that. The field of osteonecrosis has literally become an explosive research field. In the good old days, just maybe 20 years ago, this is the only reason that somebody would have used the term osteonecrosis. You see, no cells in the lacunae of the bone. That's the only reason that we have that diagnosis. However, now, especially with the bone marrow edema syndrome, we know that to find fibrous tissue out in the fatty marrow is an ischemic change. Animal studies have shown that. And it's not very interesting, but if you know that you cannot have fibrous tissue in normal bone marrow, then it gives you a very significant piece of information to make a diagnosis. Just the same information that you learned when you as a surgeon went in and found this hollow space. And that's useful. This is something I can show to my colleagues, and once we get over the fact that they haven't studied this and they don't really aren't aware of the fact that fibrous tissue is abnormal in bone. And it's easy enough. I mean, that's out there in many textbooks and articles now. But once they get over that, then there's really not a great deal of trouble getting them to understand how to make the diagnosis of this disease. But that's kind of a one-on-one situation. But the cavitation itself is, as I've already mentioned, a huge, huge advantage. If you tell me that you had a cavitation, it was a hollow space, I only have those two diseases that I mentioned. I have no other diseases that I can logically or ethically use. And even if it's normal bone, perfectly normal, not a dead cell anywhere, I can still put a statement on the end of the biopsy report saying that this is compatible, even though it's normal histology, it's compatible with either traumatic bone cyst or osteonecrosis. So these kinds of fairly unique changes are important even for the diagnosis. And talk about subtle. This is taken from a textbook, the most popular textbook of bone pathology. This is called transient ischemic osteoporosis, or what I like to refer to as bone marrow edema. The bone is alive, but look at just a kind of a wispy fibrosis between fat cells. And this is a blood vessel. A normal blood vessel can get to be maybe this size. So it's hugely dilated, and now we know why, because of that backup pressure. We're looking at a physiologic phenomenon, and we know that having these kinds of veins in bone, regardless of what bone it is, in and of itself can produce pain. One way to produce pain in this disease is to inject saline into the bone marrow. If, in fact, somebody with a hip disease has everything negative on all of their films, the last test that they do, at least in Europe, is to inject saline into the bone marrow. This is the only disease, osteonecrosis is the only disease that doesn't allow the fluids to leave at a good level of speed. Every other disease, you inject saline into the marrow and it's just gone as fast as it goes in. There's very little increase in the tension, the pressures in that bone marrow. But in this disease, the pressures go way up, and it's almost diagnostic. And of course, many patients will have pain. They'll experience an acute onset of pain with that increase in pressure. So it's a physiologic disease. And microscopically, all we see in these bone marrow edema cases is this just a few fibers kind of separating the fatty tissues. They seem to be streaming in between them. And that, I think, is what they're really doing. Eventually, we get more and more fibers, and we get larger and larger vessels. And this is another textbook example. You tell me how interesting or unsubtle this is, or how subtle this might be. We've got a large blood vessel, and then just a kind of a hint of fibrous tissue between the cells, and here between the larger fat cells. This is something we don't see much in the jaws. We have a completely dead piece of bone, and there's new bone being laid on top. This isn't remodeling. This is called creeping substitution. It's only seen in osteonecrosis, where you get new bone laid on top of dead bone without the dead bone being replaced first. Another very unique part of it. And this is from another textbook, just huge dilated veins, maybe a few white spaces where the bone cells died, and then this fibrosis. Here we have no fat cells left behind. This has probably been going on a longer period of time. So those aren't my examples. Those are the criteria I use to make my diagnosis are exactly those that are used for the hip and the knee and every other bone in the body.
Jerry, are fat cells commonly found in bone?
Fat cells?
Yeah, fatty.
Oh yeah. Anybody who's 30 years or 35 years at least or older has nothing but fat in the jaw marrow. That it's fatty marrow. And they lose the sinusoids too, because the sinusoids are the really thin vessels that allow white cells to pop in. If you don't have white cells, the sinusoids just disappear. I do find, however, a fair amount of hematopoietic tissue in NICO cases. And whether it's the disease that's keeping stimulation going, we don't know. But it's more than one would expect. But most of it is fatty tissue. And actually, if I have hematopoietic tissue here and fatty tissue here, the disease is going to be in the fatty marrow. much more readily than in the other marrow. Well, I mentioned that bone marrow edema syndrome. It's the name itself will have to just wash out over time, but I like the term bone marrow edema syndrome. These are the pain-related ones when the syndrome is added to it. Microscopically, it's bone marrow edema. And it's just what I've been showing you. Dilated veins, this wispy fibrosis, it's called reticular fatty degeneration. There can be hemorrhage. This is a sign of a little microinfarction. Usually we don't catch that slice of tissue just at the place where the thrombus is, but we can see the blood that hemorrhaged around that dead vessel. And we may, if we get lucky, see the actual microinfarctions themselves. And this is a disease, and this has been proven in animal models now. You can produce this focal osteoporosis by diminishing the blood flow, slowly diminishing the blood flow to the end of the long bone. And the ends of the long bone are in the jaws. The equivalent of the ends of the long bone are the maxillary tuberosity and the retromolar pad of the mandible. Even though you'd think that they're closer to the main entrance of the vessels, those are the equivalent of the ends of the long bones. So osteoporosis is a pretty common feature, and that really is a fairly common radiographic feature. But osteoporosis on just a little period is pretty hard to interpret. And then we get aggregates of fibrin and platelet in many of these, and we know now why, because we've got these coagulation disorders. Is it found in many, many cases of osteonecrosis? I think of it as a mild form of osteonecrosis, and you can see that it's found in the majority of cases, and that's true in long bones as well as in the jaws. It's also seen in probably 90% of the cases of osteoarthritis, and there are some literature reports out right now that are saying that they wonder if arthritis is produced from the bottom up instead of from the top down, because the marrow dries out and there can be no nutrition going up to the cartilage, and dried out cartilage is really the basic phenomenon of osteoarthritis. If it dries out, then it can be damaged much more readily. So this is not proven, but it's certainly a good strong speculation in the bone pathology literature today. There are all kinds of animal models. Pigs sent into hyperbaric chambers 40 and 50 times. We use hyperbaric chambers as a therapy for osteonecrosis. The way it's caused, one of the first animal models was to send those pigs in. Pigs just happen to be very susceptible to this disease, probably more so than any other animal. But there have been monkey models and guinea pig models, and people have tried, have been able to produce this disease with a variety of different techniques, all of them having to do with a slow diminution of blood flow into that bone. What's the prognosis of bone marrow as opposed to bone marrow edema as opposed to normal osteonecrosis? We just don't know. It's too new a concept. The fact that there are two kinds of osteonecrosis is just too new for us to be able to say. And I've already talked about the intramedullary hypertension that's associated with that disease. I don't think I'll talk about that.
So Jerry, in essence, what you're saying is that the bone marrow edema is also considered a disease?
Bone marrow edema or bone marrow edema syndrome is a disease. It is on the mild spectrum of osteonecrosis. There is some discussion in the bone literature about whether it's a separate sort of self-contained disease or whether all cases will eventually go on to full-blown osteonecrosis. I have a problem looking at my tissue and answering that question because I'm looking at little chunks of tissue, often from around a hollow space, and that hollow space might actually represent true osteonecrosis, old osteonecrosis.
You know, one thing that I think about when I look at all this stuff is that if you read the medical texts at the turn of the century and before, they talk about, there's doctors that are saying that you have to walk 6 miles a day in order to maintain health. I mean, what do we do anymore other than the sports that we participate in today that we think get us in shape are produce nothing like the robust health that being a rancher produced even 50 years ago, okay? Because these people would walk all day long, they would use their bodies all day long in a whole different way, in a much more normal way than the sensible way that we do our athletics today. And, okay, you get into the fact that I do Prozac orthodontics. Well, the problem begins when that child doesn't breastfeed because the milk comes out of the bottle so easily, they aren't using their tongue pressed against the roof of their mouth to fight for that milk, and so you see a depleted maxilla. So you put them in Prozacs and put very light force on it. What happens? You get bone apposition. What happens in a society where people don't chew anymore? What happens? I mean, we know if we pull all a person's teeth, that bone's going to necrose. I mean, we look at it. I mean, why do we reline dentures every 2 years?
Well, it's not necrosis in this sense. It's atrophy
Atrophy, ischemia, and
from the top down.
okay,
Yeah.
but what happens when we pull a tooth and bone that was meant to bear up under force is no longer? It's worse than having a poor diet where we don't have to chew anymore. What do we chew anymore? I mean, in this modern diet, and then you pull the teeth, and then what type of stimulation does that bone have? It could be just a complete absence of the proper stimulation that leads to poor long bones, poor bone around the teeth, or poor bone in the maxilla and the mandible, and I mean, what do we do anymore? We don't, we eat soft foods, we lose our teeth,
That's a good comment and kind of a commentary of despair. What do we do? Because we're not really using our dentition and jaws the way we used to, just as we're not physically working the way we used to. And I don't have an answer to that. I do know that disuse osteoporosis is a form of regional osteoporosis or bone marrow edema. The pressures, the outflow from a bone that's in a cast, for example, just is not very good. And that's been known for generations now. If you put a bone in a cast, a leg in a cast, it's going to look osteoporotic and the rest of the body will look fine. The treatment for bone marrow edema syndrome in the hip, where it normally occurs, is bed rest for 6 months. So,
But what got it to that point in the first place? The fact that it can't bear stress anymore may not have much to do with the fact that what got it to that.
What got it to this point? Yeah. That is a good question, and I wish I had an answer for you.
How do you define the edema histologically? Because it is more fluid, it means there's less of something else extended in a specific way.
No, it's the question is, how do you define it histologically? And it was defined right here. These are the histologic things you find. You find this thin and inactive bone. That's really the major change in bone. And you find areas of hemorrhage. But the two major features, the things you have to have for this diagnosis, is fibrous replacement and these wide blood vessels. That's a very simple thing if you understand that you can't have wide blood vessels normally and you can't have fibers normally. But most of us in pathology have not studied basic bone marrow. I mean,
That does not represent interstitial increased fluid necessarily.
no, we don't see the fluid. We see the changes from the poor blood flow, the ischemia. And we may see infarction as well.
So there is not necessarily increased fluid.
The fluid has been determined from physiology studies, not from histopathology.
Right. Because it's a confined space.
Right.
So why did you choose the word edema? Because, for instance, if you were to contrast it with the edema of cardiac failure, for instance, it's presumably very different.
The people who use the word edema use it because they want to emphasize the fact that this is fluid dynamics. And I didn't make up that name. That's somebody else who's used that term. Several other people have used that term now. So I'm just I only have two choices. I have either bone marrow edema or transient ischemic osteoporosis. And in my kind of tissue, I'm dealing with curettage chunks of tissue. I don't have the whole end of a long bone, so I can kind of make out these changes on my individual chunks of tissue. And so I prefer the bone marrow edema terminology. But it is you're right, it's a physiology name, but that's not so unusual. We have pathologic descriptions of many physiology changes. It's a good point, though. Yes?
Have you ever found a biopsy of osteoporosis from someone who has not had any dental work?
The question is, do we find this NECO or osteonecrosis in people who have not had dental work? And of course the commentary was that it's hard to find somebody without dental work. But of course, there is one form of this in young adolescent boys, in the hip. It's exactly the same thing that I'm looking at microscopically. But nowadays, adolescent boys, a lot of them don't have any kind of dental treatment except maybe some sealants placed on them. I haven't really looked at that though, but what really makes or intrigues me about that issue is that so many of these are third molars. And if you have this hollow space, even if it's present for 20 and 30 years, and by the time you find it, there is all kinds of dental work, there probably are, at least among the young people now, there probably are people out there with very little dental work. You know, you're relating, I'll get to that in a second, but you're relating to dental work, but there's a whole nother issue. If you have somebody with one of these coagulation disorders or some underlying susceptibility for whatever reason, maybe they're taking corticosteroids or maybe they're taking replacement estrogen, if they have that problem and you now work on them, you inject, you give them a mandibular block with enough epinephrine to cut out 70, maybe even 80% of the blood flow in that bone marrow. If they have a susceptibility to begin with, it may have nothing to do with the dental, the teeth themselves. It may have to do with the anesthetic. Bob?
Gary, maybe throw a little different light on what the lady asked you about our youth and their susceptibility to osteoporosis. And our habitat scan clinical trials were done this year, which you're very much aware of. We had about 60, I don't know, get the odd number, over 60, but less than 70 young people that we had scanned that had no dental work that didn't perform on them at all. We found every one of those had healthy jawbone. We didn't find any necrosis at all in that age group between 6 and, I think the youngest we did was 6 and the oldest we did was 16. Everything above 16 I considered an adult based on our study on what we're seeing. And they were the ones that I really used to fine-tune our color charts on green as being good cancellous bone as we used. We just didn't find anything in there.
Bob's comment was the cavitat didn't find any cavitations or NECO lesions in his young sample of about 70 patients. And he's been finding plenty of them in the older people. Okay.
Since you're getting all these samples, do you constantly check for fluoride, presence of fluoride in these bones?
I have tried to get people to, I don't have the machinery to do that, but I have tried to get people to check for heavy metals and fluoride, and it's just too expensive. And my center is too young yet to have done that. My goal is to have a series of grants coming in, but that's still in the future.
What Haley's learned is improve the mechanics that we're supposed to down the present time on that thing.
Boyd Haley is getting a very expensive machine that will be able to do, I don't know about fluoride, but it ought to be able to do that.
There's some published research in Germany from Darmstadt that shows a lot of metal residues around those lesions, but also form aldehyde and other type dioxin and other things. So that's published in a good journal.
I just wanted to show you some of the cystic lesions or cavitations in long bones, and these are taken from atlases, just standard atlases of bone pathology. Here's one that you might recognize. Every once in a while you run into one with a glistening wall, and this is because there's a fibrous, sort of a fibrous encapsulation of the wall. I didn't show you this. This is that chalky white stuff, the dry rotted bone. You can scrape this and it will be very hard to bleed. There's been a bit of hemorrhage down here, but it's difficult to evaluate because this is also hematopoietic marrow. So this whitish chalky bone is one of the classic features of this disease. Yes?
Vasoconstrictors and anesthetics may be a very important subject, and I just wondered if anybody knows of a longer-lasting local anesthetic without vasoconstrictor that does not have a high toxicity factor, because everyone I've looked at is extremely toxic.
Yeah.
That's another problem.
That's a real question. What do you use?
Huh? Does anybody know of one they like?
Great. Marcaine, you can get that without
And the
epinephrine.
toxicity factor's not too bad?
I don't know about the toxicity factors.
No,
I
everyone
have to
else
ask you
is
guys that.
horrible.
Chris, you had a question or comment?
I've used Marquine for years, and without epinephrine, it seems to work well. I'm really concerned with toxicity. The Lidocaine, Duranest, it has less toxicity. It's much more expensive, but I do that. I had a woman last week that she got a little anaphylactic from Marquine plain. So I had to do some quick work, and I muscle tested her, and it was the Marquine. And I checked her for Duranest, and she did fine. Did a bunch of surgeries on her. So Duranest plain, and buy the multi-dose vial.
Who put that down?
I don't know.
Duranest?
Yeah, Duranest, Duranest, has less toxicity than Marquine and lasts just as long.
What do you mean by the toxicity? You're talking about the aniline?
The way it's breaking down, the way
Well,
people feel if you use a lot of it, okay, and the way the body metabolizes it. And based on that, if you're doing multiple surgeries, let's say you're doing a whole arch, maxillary arch, start at one side first, do it in thirds, and anesthetize, finish, anesthetize the next third and finish, so you're not building up these toxic levels. There have been several cases of plastic surgeons where their patients are anesthetized for 7, 8, 10 hours, and they die of lidocaine overdoses. And you can do the same thing, believe it or not. You get real toxic real fast with this stuff, so use your head when you do the surgery. Use small doses, use small areas at a time, and work your way around. Let the body metabolize what you're using. And don't use any vasoconstrictors. There's no need for vasoconstrictors in dentistry. That's part of the problem that we're seeing here.
I think this might be a good topic to reserve for the panel discussion at the end, because there should be a lot of interaction. I will say, relative to that question, now, I have no idea if that is causing any of these problems, but many cases that I have had to defend have started in the dental chair. And they aren't necessarily bone surgery cases. I recently helped somebody who just had an MOD placed, onlay, I think, wasn't amalgam, but there was no bone work done at all, or very, very minimal bone work. And the only explanation that I can think of is why it happened is the vasoconstriction. But because there were enough cases, I wrote with one of my contributors from Washington, I wrote a paper for the Journal of Prosthetic Dentistry. It should be out this month, next month, the month after, about a disease I called subpontic osteonecrosis, because many people, that's how the disease started. They had a pain there, and the tooth went through endo and extraction, and then after 6 months, they said, okay, the pain's gone, so let's do put a bridge in there, and that starts the whole process all over again. And there was nothing in the literature that would allow me to defend these people. And so we put together 38 cases that do exactly that. We'll have a reference for those kinds of cases. Not all of these, just as in the jaw, not all of these hollow spaces have nice smooth walls. Most of them, in my experience, looking at over maybe 100 or 120, is that a lot of the bony walls are ragged. And it's not at all unusual to have multiple sites. I can't even tell you how many times I've been looking over the shoulders of a surgeon and saying, well, look, the x-ray looks a little strange. Just anterior to that point, why don't you use an Explorer or use some kind of a curette to press firmly on that wall, and they'll fall right into another one. That's not unique at all for the jaws. It's just part of this disease. And of course, the cavitations I've already mentioned. They're only, everything that can produce a cavitation is an ischemic phenomenon. The subchondral cysts is really a form of ischemic osteonecrosis. The osteoporosis, we've already talked about that regional form of osteoporosis, but it's not unusual to have hollow spaces in the bones of osteoporosis, regular osteoporosis. Traumatic bone cyst. And then there's this weird radiopag disease of the jaws. It's just got a bunch of traumatic bone cysts. I think this is an ischemic disease, but we just haven't proven it. So it's a very limited thing, but of course when I get tissue, you may have removed all of this, or the disease may have removed all of this tissue, and all I've got is this little bit of bone, damaged bone around the outer edge that you've scraped off. I am helped, and any pathologist would be helped greatly by a good description of what you found, because I can give you a better diagnosis with a good description. Also, if you can assure me that no rotary instrument touched this sample, because these round burrs go at high enough speed that they can pull the bone cells, the osteocytes, right out of the bone, and that can give me an artificial death look. I use very, very mild, it's formic acid. You could stick your finger in it, really. It's not quite as weak as acetic acid, but it's almost there. I use a very mild acid just so that I can evaluate what the bone, the life and death of that bone. But it's really the marrow changes that give me the best diagnosis. However, if you get in, once you've gotten into the cortex and use hand curettage, that is, and I know that, that's a tremendous help in the diagnosis. So those are two points of sort of housekeeping that I'd like you to keep in mind. Describe what you saw, and don't put a rotary instrument in there until after you've given me a biopsy sample. And there's always a question, do you give biopsy samples? I don't know. I think that I'm a pathologist, and so my general feeling is that especially if you're removing something from bone, you really have to send it off somewhere to have it analyzed. And if you're working with another pathologist, I'd be happy to send them information that helps them to make the diagnosis. But if you're not, I'm just in the process of analyzing my data, and it looks as if about 1 out of every 600, maybe even a little less, about 1 out of every 600 cases sent to me as a NECO case or osteomyelitis, osteonecrosis, is in fact a metastatic malignancy or a primary bone cancer. And so if you are not sending tissue off to find that out, just for that one reason alone, that's the kind of risk you're taking, about 1 in 600 of losing your license for that exact reason, because that is a definite reason to lose a license. So keep that in mind. Not all of these cavitations are large. Some of them are very, very small, as you would expect. You get little infarctions. How about multiple sites in the jaw? We've got 50 to 80% of people who have osteonecrosis in one hip will get it within 10 years in the other hip. It shouldn't surprise us at all. Certain bones are susceptible to this disease. The knee and the hip, because of the tremendous pressures placed on the ends of those bones, and the jaws perhaps because of pressures. Somebody bruxing, I don't know, but the jaws probably are what's more significant in the jaws is we've got what other bone has so many infections, what other bone has so much trauma. I mean, it just overwhelms the amount of infection and trauma in other bones. So this is a very typical endpoint for osteonecrosis of the hip, complete collapse, and this is a very, very typical treatment. They don't redo the bone. They don't go in and scrape it out. They cut off the end of the bone and replace it with some kind of metal. And I say they don't scrape it out, but I'm really kind of lying there, because they'll try going in and scraping. They do what we do. They go in and curette the lesion. There's so much dead bone in the ends of the femur in these examples that they usually don't want to take it all out, because there is some girdering left behind. Some trabeculae are doing some support work. So they go in and they call it core decompression. They just remove a bulk of it and hope that with new hemorrhage and better healing, it will fill in. Is this a common end stage for people with osteonecrosis? Well, I've told you that most of them go on to collapse. How about once they've got artificial limbs in there? My father has 2 in his knee. You can see that it depends on the stage of the disease. And that's where I don't know about prognosis in the jaws. I would assume bone marrow edema examples would have better prognosis from treatment, but the ones that are these foul-smelling, tarry samples of bone, I suspect are going to have a worse prognosis. But you can see that there's a steady loss of these prostheses in the joints over time. It's not, just because you make it through 5 years doesn't mean that you're free and clear. And that's not so unusual for the jaw cases either. Okay, so the absolute point that I have to make is that we have no evidence that this is not the disease that is found in every other bone in the body. It's been given a wide variety of other names. This drawing is in the handout as well and on the home page or the web page. But it's only been in the past decade or 15 years that the bone pathologists, the orthopedic surgeons, have realized this is all the same phenomenon. And now they're all lumping it under one disease name, osteonecrosis. We used to have all kinds of different names for these things. There's a textbook that came out, the Orthopedic Academy, the American Academy of Orthopedic Surgeons, publish a textbook on osteonecrosis once every 5 to 7 years. And the latest one has, I'm a co-author of the coagulation chapter, and this textbook treats jaw cases just like any other form of the disease. It's a very nice book, and Urbaniak is the main author. The second author, John Paul Jones, is down in the San Diego area. He has an osteonecrosis clinic or institute. So what is the difference between what goes on in the jaw and what goes on in the hip? I think this is a big part of it. If somebody has pain in the hip, the doctor doesn't immediately think, oh, psychology, or nerve damage. They think there's something in the bone. It's just the standard first way to try to figure things out, and they send for the appropriate treatment. In dentistry, we take an x-ray, and often it's only a Panorex, which is horrible for trying to find this type of disease, although I've got people who routinely find it on Panorexes. I have difficulty with it. But I've had at least 7 patients whom I have had personal contact with commit suicide, partly because of the pain, partly because of the depression associated with pain, partly because of the sort of patient abuse that they have had from docs who say, oh, this is just a bunch of nonsense or quackery. I have always been the person who has been willing to support his students when they get involved in lawsuits, if I can ethically do so. But for every one of that, I'll deal with 3 or 4 NICO cases. Are there a lot of lawsuits going on? Since I got this in the early 1980s, early 1990s and late 1980s, I know of no more than maybe 12 or 13, 14. And the early ones we lost, the early couple we lost, but that's not happening now. Well, let's just quickly go through what this stuff is like in the jaws. This is an example of an autopsy case. You can see the discoloration is a combination of necrotic debris, this fibers, and old hemorrhage. And this is, you can kind of make out the cystic spaces. This would be a fairly characteristic cavitation, but not a large one. Also, you see beneath the inferior canal is a hollow space. There's a little tissue tag covering part of it. But that's essentially a hollow space immediately above the cortex. This is a case that had been worked on 3 times. They found 3 different sites of osteonecrosis, and yet probably never would have somebody have gone down that far unless there was a direct connection more superficially. Look at the canal itself, all this discoloration. There is no bony canal. It's been destroyed by the process, and there's just this gelatinous marrow. If you were starving to death, you would have gelatinous marrow. If you were given chemotherapy, you would have gelatinous marrow. Those are 2 common, or not common, but classic causes of osteonecrosis, especially the bone marrow edema form. And do the jaw cases go back in history very well? G.V. Black wrote about this disease in his textbook, classic textbook. But most of the work really started in the mid-1970s, including your reference to interference fields here, and of course Bohl was working in the 1950s. Roberts and Ratner both started their work in the 1950s. And the first real report from outside of our country was 1981. But even before G.V. Black came along, this was a disease that every dentist of last century knew about. There were a lot of people who had phosphorus poisoning, a lot of people had mercury poisoning. This was a time when mercury was given in liquid form for patients to drink. They called it salivating because the saliva would just pour out of these people for months afterwards. They would mix it with a milky, chalky material, and it was called calomel. And there were, in those days, a lot of people. It wasn't so unusual, if you read the dental literature from the 1840s and 1850s, for a patient to come in with pain and the dentist pulled a tooth and the jaw came out. There are examples where half of the mandible pulled out with the tooth. And, you know, even osteomyelitis would produce pus and ooze, and there would have been some hint to the dentist beforehand that there was something wrong with the bone. And this had to have been osteonecrosis. They had a name for it for those who got phosphorus poisoning from these having phosphorus bubbling, making matches in their cottages and little homes. The name was phosphijaw. It's just a standard. It's not even defined in the old dental journals. It was assumed that everybody knew what a phosphijaw was, and this is an example of phosphijaw. So it's a combination of heavy metals are known to produce osteonecrosis and ischemic damage in bone. That's no big secret. That's not controversy at all. But normally we're talking about very high doses. The jaws are the bones most affected theoretically because there's chronic inflammation, periodontal and gingival inflammation constantly there. And these heavy metals, there's more blood flow to those areas of inflammation, and theoretically the heavy metals travel to sites of inflammation and then do their damage. So this is not a new disease at all, and if you really want to go back, there's a prehistoric case of a dinosaur, supposedly 100 million years ago, who has osteonecrosis of the hip. So it's not anything new at all. My personal involvement goes back to about 1987 when my state government asked me to look at Dr. Roberts' examples. And altogether, we looked at over 340 cases, only 10 for that legal business. But every one of his cases was called chronic osteomyelitis by other pathologists, medical pathologists, before I got involved in this at all. This is over a maybe 25-year period. So I think it was a total of 9 different pathologists in 3 different hospitals. And they all called it chronic osteomyelitis, and yet he was being accused of going into normal bone. Biopsy reports apparently don't mean much if you're a board who wants to take away a license. No, that's not true, because it was the biopsy reports that saved the day. And my first presentation of this was in Dublin, Ireland. But now we have a histopath paper, which is totally inadequate now because of the bone marrow edema concept. I've got to write another one. And we started to find coagulopathies only in 1994. Gluck at the University of Cincinnati wrote and said, look at this, 72% of my osteonecrosis patients have coagulation disorders, and it all makes sense. And I went and begged him to do the same. I literally begged him to do the same research. So all those coagulation studies, I had nothing to do with the design, the material and methods. All I did was give him the names of patients who had osteonecrosis. And that's worked out pretty well. We have the first independent follow-up study, not done by the surgeon actually doing the work, which is a lousy way to do a follow-up study. The first one was done by myself in '95, and then the first cases of coagulation were reported in 1996. So this is all very new stuff, even though many of you have been treating cavitations for a long, long time. We started a little late, so another 5 or 10 minutes, is that okay? I've already alluded to this question. Why the jaws? Why are they so heavy into this? In the hip and in the knee, we can understand that because they really get a huge amount of trauma. We don't know about trauma from occlusal pressures, but is anybody here, is there a dentist in this room who would not think that bruxing would be the cause of some teeth dying in somebody who doesn't have any caries, doesn't have any periapical disease, but the tooth is dead anyway? They don't have diabetes to explain it. We just assume trauma. It could be acute trauma. Somebody gets hit in the face, they get slugged in the face. Or it could be chronic trauma. Well, I think that same phenomenon probably is occurring in the bone. And if somebody is bruxing, they probably are not cutting off their blood flow nearly as much as the apical area of a tooth or tooth pulp. But to a certain extent, there has to be that same phenomenon. And it's not at all unusual for me to see what I've taken to call mummified pulps. Somebody sends a tooth in thinking that it's dead, and it was dead by all of their tests. And it's just little stringy strands of fibrous tissue. Hardly any blood vessels left. It's still alive tissue, but the nerves are gone. The blood vessels are just barely present, and it probably became fibrosed from ischemia, chronic ischemia, outflow problem through the apex, and then just mummified, just dried up. And if that happens in a tooth, I don't see why it can't happen in the bone around that tooth. But nevertheless, we have other reasons. Trauma is only one reason for osteonecrosis. And when I say trauma, I'm thinking in terms of extractions, even endodontic therapy, anything that would cause an inflammation within the bone marrow space. Corticosteroids, I mean, it's not so far removed from the time when we gave corticosteroids after most wisdom teeth extractions to prevent swelling. And corticosteroid-induced osteonecrosis is one of the standard forms of osteonecrosis. That's not my name. That's in the bone literature in lots of places. And usually it's considered to be dose-related and duration-related. If you give corticosteroids for 4 to 6 weeks or less, supposedly your patient is safe. However, there's one case that occurred, not the jaw, but the hip just collapsed 6 months after a simple Medrol dose pack, a 1-week course of therapy. And that's kind of scary, but there are lots of reasons for corticosteroids causing this disease. One is every fat cell in the body puffs up a little bit, and I've told you that the fatty marrow is what most of the older people have, or middle age or older. So every one of those cells puffs up, but there can be no expansion. There can be no buffalo hump. There can't be a big belly. And so what happens is it just increases the pressure inside, and that puts more pressure on those veins, those exit veins. Corticosteroids also irritate the endothelium, and those endothelial cells respond in several ways. One of the ways they respond is to release clotting disorders or clotting factors. And if it's a patient who happens to have a problem with clotting factors, then there will be more of them released than normal. So there are several methods whereby this could work. There are other medications. Probably estrogen is the biggest one. There is one paper out there that estimates the risk of getting a thrombus somewhere in the body from taking Premarin or replacement estrogen therapy is a minimum of 40 and maybe 80 times higher than normal. And they concluded that nobody should be put on replacement estrogen without testing for coagulation disorders. And he was only looking at one kind of clotting disorder. We now are routinely testing 13 different coagulation disorders in our NICO patients. And it's not going to happen. It's $1,000 to $1,300 to do this whole battery of tests. And nobody's going to approve that just to be put on estrogen. So we'll continue to have a problem, I'm sure, with estrogen. If you look at real alcoholics, Skid Row bums, about 17% of them have osteonecrosis of their long bones, their legs. We don't know if it's from direct damage or whether it's liver damage and indirect from that system. But there are lots of clotting disorders. Sickle cell anemia or disease is another one, and then we've talked about the coagulation disorders. Yeah.
Could you discuss a little bit more about the genetic profile of the coagulation disorders and are there other signs that you think suggest that might be in that category?
The question is, he'd like a little more information about the genetic profile of these clotting disorders, and that what I've done in the handout or on the website as well is in the table where I talk about clotting disorders, I have specifically if I can find it here. I've specifically listed what studies have found to be the proportion of people with acquired and clotting and hereditary disorders. So let me just give you a feel for this. In hereditary types, in the normal population, anywhere from 2 to 6% of us have a clotting disorder. And most of us now get along just fine, or if we have a problem, it's sort of almost a subclinical problem. So it's not that this is not a common phenomenon in our population, at least in Europe and the United States. 2 to 6% is a fair chunk of the population. But if somebody has deep vein thrombosis, which is always held up as kind of the classic disease for clotting disorders, then their chance of having one of these clotting problems is above 50%. So we don't know the cause of all of the deep vein thrombosis. And most of those are acquired. Only about 9% are hereditary. But in osteonecrosis, we have anywhere from 50 to 75, almost 80% of our total coagulation, or of total patients, have these hereditary clotting problems. And the acquired are much, much less. It's not at all unusual, however, for somebody to have both a hereditary and an acquired clotting problem. I think I didn't make up a slide to answer your question. It would have made it much more clear. But let me just recommend you go to that table. And almost all of these coagulation disorders are autosomal dominant. So what you see in the family should be a history of maybe strokes at an early age. These are families with serious coagulation disorders. Most families, the problems that have arisen have been such that nobody put a pattern together. But if they do have multiple clotting problems throughout that family, and it's not unusual to find 3 and 4 different coagulation disorders in our NECO patients, then I always ask for family history of strokes at an early age, 40s, early 50s, heart attacks, or hip problems, hip or knee problems at a relatively early age. That doesn't tell you anything more than sort of hint at this kind of a thing. But that's really about all I can do with the patients I work up. The last point I'd like to make is this whole business of nerves. This is a painful condition in many patients, if not so far in the vast majority of patients that I have some experience with anyway. Keep in mind that the pain from this probably is quite a bit enhanced by the fact that we have the trigeminal nerve. If I can remember correctly, it's something like 40% of the brain is used to interpret signals from the trigeminal nerve. I mean, it's not a small system at all. And it's a very complicated nerve. And recent animal studies have found that branches or stimulation of the trigeminal nerve out here can produce either messenger RNA or some other signal change all the way down to the end of the spinal cord. So the signals that are going in, we used to think that any damage, for example, bacteria or fungus, out here where the teeth are, can get into the Gasserian ganglion. They can literally travel up into the Gasserian ganglion. That's easily been shown several times. But now we have to think that whatever the damage is being produced in the Gasserian ganglion, there are signals that are damaging or some kind of material, toxic material, whatever. There is a signal that is producing change and in some instances damage in the second level neurons. And so some of these changes that when somebody perhaps gets better in their knee because you cleared out something in their jaw, it might literally be hardwiring that you've improved. I can't explain these people who get better immediately in their knees when you remove a NECO cavitation. But we have to assume that trigeminal system can explain a lot of the distant forms of the disease or distant association with other diseases simply because of what the neuroanatomists are finding out. In a normal, I just want to leave you with kind of an impression of the nerves in this disease. This is dead bone. You can see the fat or the osteocytes are missing. But the fatty marrow here isn't too abnormal. I don't see much in the way of fibrosis, and the blood vessels aren't too dilated. And this is just a nerve. It looks like a worm inside the fatty marrow. There's no fibrosis around it. It's just a worm or a piece of string lying within that marrow. Very well demarcated from the surrounding. This has got a little bit of wispy damage to the marrow, but it does show there's a special stain for myelin. This is Luxol Fast Blue, and it shows that even the small nerves in the jaws have a lot of myelin covering them. They don't lose that myelin until they get into the teeth, most of them. And probably the ratio is about 4-to-1 or 5-to-1 nerves in the jaws have myelin covering as opposed to those that do not. So if we find nerves without much myelin, then we can assume that's at least a pathologic state. We may not be able to determine what produced it. But in this disease, the nerves, it's not unusual. I mean, I find plenty of normal nerves. Don't get me wrong, but this kind of a nerve where it's kind of just splayed out and the fat cells are actually indenting the nerve. I assume this is an edematous nerve, and perhaps because of increased pressures out here in the fatty tissue, which we of course can't see microscopically, it's putting pressure on that nerve. And I guess this splayed effect and the indentation, I presume, is part of physiologic damage. But I have a neuropathology friend who kind of agrees with me, but I really haven't done much in the way of studying of that phenomenon.
Can you give us the clinical picture of this?
These are all from atypical facial neuralgia patients, every one. And this is very significant. Here we can see the nerve. This is that special stain, so the bone looks a little funny, but you can see also the bone is fairly dead here. And we have a huge blood vessel here. Remember, that's a sign of this bone marrow edema. And also the fat's been replaced by fibrous tissue, maybe a few little fat cells left. But look at the green-blue area is where we have myelin remaining. We just get little pieces. So essentially what we have is electric wiring that's totally exposed now and capable of touching one another without the insulation. And I can see where perhaps that could explain not so much the atypical facial neuralgia, but the trigeminal neuralgia cases. I have tried to find these kinds of nerves in trigeminal neuralgia as opposed to atypical facial, and I can't find any strong correlation with this phenomenon. It just seems to be something that occurs in maybe a third of the nerves that I find in my biopsy samples. And here's another one with kind of fibrosis separating a little bit of the fibers. And instead of being all nice, this is a good large nerve. This should be totally green-blue, but we're down to about maybe half of it only has myelin. The rest of the myelin is gone. And then if you with a needle or a scalpel just nick the edge of a nerve, you don't cut it, you just nick it, you can create the world's tiniest traumatic neuroma. They're called nerve tufts. But they have most of those, in real life they probably would look like a little bit of a sea, what is it? Anemone, sea anemone. I'm from the mountains, I can't get those words out. And I can imagine where putting pressure on the edge of this would produce a huge pain signal. They're not very large nerves, but the fact that they don't have the insulation, the sheathing around them, is very significant. And you know, you'd never find these. Is it very common for me to find them in my samples? Well, first of all, curettage samples aren't the best way to look for these things. But I found probably I see a nerve of one kind or another in less than 4 or 5% of the biopsy samples I get. And most of those look perfectly normal to me. And I've stained hundreds of these with this special stain. And of those, well, this isn't the special stain, but what I showed you before. And the majority of them have plenty of myelin. I don't know what is the difference, why in some patients they lose their myelin and in others they don't. But these kinds of cases, this was from a very large chunk of tissue, and you can see the the ischemic damage with just the fibrous tissue here. Most of the bone looks living, still alive. But this is just dead liquefied fat with some old hemorrhage mixed in there, and these spaces are these yellowish bubbles that the surgeon finds, the oil cysts they're called. But look at this, we got a nerve just floating in this. This has got to be toxic waste. And the nerve is totally floating. 3 nerves are just laying down in this material. And it has to be producing damage to that nerve. So it is possible that you can have nerve damage in this disease, and that may, if you damage the end of a nerve, it is possible for that damage to extend in skip areas. Doesn't have to be a direct extension, but in as far as the Gisserian ganglion and the spinal nucleus for that trigeminal nerve. I mean, that's been shown in animal studies. And as a matter of fact, the only animal model for trigeminal neuralgia available today is I think it's a rat model. Might be a guinea pig. But the way they produce it is they break off 4 teeth in a quadrant and just let the normal oral bacteria get in there and produce pulpal infection. And that is the model for trigeminal neuralgia. It has nothing to do with the brain. The only model available has to do with the teeth.
Jerry, would you consider that a osteogenesis of MS, for instance?
The question is, could this be related to MS? I'll just answer this as my final comment. We reported in '94 9 cases. We were thinking along those lines exactly. And I was doing all these special stains, and Bob McMahon in Indiana, who, after Chris Husser, is about the one person who does more of these than anybody else in the country. Bob McMahon was drawing blood and sending them to the University of Maryland. A neurophysiologist, MD, PhD type, had recently invented a test to show myelin antibodies not myelin antibodies to central nervous system cells, but to peripheral nervous system cells. We could do it for central cells quite a bit before this, but she was the first one to determine the peripheral. So now you and I have absolutely 0 antibodies against our nerves. The immune system doesn't really know that our peripheral nervous system exists. There is nothing that is being made against the nervous system outside of the central system. So to find any antibody is quite unusual. And the antibodies that this test shows or finds are really in a group of diseases called demyelinating diseases or demyelination diseases. MS is one of those. Guillain-Barré is another one. There are several other demyelinating diseases. And of course, we have myelin stabilizing medications for those kinds of diseases. Many of those work in NICO patients, at least initially. And all of that led us to send blood to Dr. Koski at the University of Maryland, and she was kind enough to use some of her own grant money to run off 10 samples for us, and one of them just went sour, so we couldn't use that. But out of the 9 examples that we have, our theory was that we now have these nerves in a chronic disease state. And the myelin, we know, at least in some individuals, is breaking down. Therefore, the immune system is now exposed in a chronic way to myelin. And does this produce myelin antibodies? If it does produce myelin antibodies, and you can see that it most certainly does, Guillain-Barré, MS was not part of this particular study, but the MS patients would be even greater than Guillain-Barré. But Guillain-Barré is kind of the standard demyelinating disease that is used in these studies. But certainly, the average for our NICO lesions was higher than the other demyelinating diseases, which are very well established, and there are animal models for almost all of these others. So we do have at least this little bit of proof that a focal area can produce antibodies against something that normally your body does not know about, the myelin, the insulation on your nerves. And of course, this was peripheral blood we were drawing from. We did not draw the blood from the lesions. So we know now that, of course, we need a larger study, but this is a very expensive test, so that's been holding us up. But we know that there are now antibodies coursing throughout some individuals' bodies. We know from only one example that this antibody level went down to 0 after we cleaned out a lesion. We only did that once, but that was kind of nice that it worked. So that's not proof, but it's pretty strong evidence that it was the focal area that was producing these antibodies throughout the body. Well, if that's the case now, these antibodies are able to touch the myelin, the insulation of all the nerves all over the body, and it seems to make sense that MS, Guillain-Barré, and these other demyelinating syndromes can be helped by cleaning out the garbage in somebody's jaw. This is not a real problem with other bones because they don't have the size nerves that we deal with. They have real tiny sensory, mostly parasympathetic nerves, and they're mostly there for vasoconstriction and dilation. It's only the bone, and you saw that autopsy case, it's only our jaw bones that have these really huge nerves and can really stimulate the immune system. I said that was the last thing, but there's one more picture I at least want to show you. These are just some of the clots that we've been finding. All right, very soon. I'm getting at least a few cases now of these hollow spaces sent to me now that people have digital cameras in their offices. And I only have maybe 6 or 7 of these, but it's hard to find a good picture that shows the internal aspect of this because of the hemorrhage or the darkness inside these holes. They don't show up very well in 2 dimensions. But what I did is there's a section in the NICO, I call it NICO stuff, on our webpage. And the first picture you see when you go to clinical features of NICO is one of these cases sent in, and it's pretty good. You can see the internal wall, and the picture was taken immediately after taking out the lesion, or after unroofing the lesion. So if any of you have those kinds of things, I would appreciate it. This is that autopsy case that I've shown you. This was the first one. This is the fellow who donated his head to me when he died. And that was only because he had had both trigeminal and atypical facial neuralgia of different branches. And the only thing that had helped him was finding, as I mentioned, 3 NICO lesions. But it was all starting to come back, and I can see why. But I showed this picture. I gave a half-day course to the pathologists at the Armed Forces Institute of Pathology about 3 years ago. And the head of the bone pathology section is one of the national experts on this disease. And when this picture came up, he said, "You should have showed this first, because there's nothing else that this can be," which I didn't know. I wasn't aware of until he informed me. So this kind of blotchy discoloration in multiple sites is one of the characteristics. But what I wanted to show you really is this. This is the second autopsy case. I am getting cadaver jaws from one of our medical schools in our state, and I only have altogether, I've done maybe 24 jaws. And this is the only one that has a really full-blown NICO lesion. It is a patient who had chemotherapy for a metastatic disease, and so I assume this is related to chemotherapy, but I don't have much in the way of medical history on any of these cases. But this is bone, and you can see a little bit of a kind of this pearly internal surface and a little slight translucency outside. This is condensing osteitis. You can see what it looks like radiographically. And this hollow space that is so dramatic is really, there's not much to show on the x-ray. There's another hollow space back here, and then, of course, the very large one. But this condensing osteitis, I would have to say that if I were, well, it doesn't want to. if I were to look at this, I would say this is enamel in an odontoma, or this is dentin. It doesn't look like bone, but microscopically it is bone. And if you look at the inferior border and to a certain extent the superior border, it kind of explains a little bit. The cortex is fed, the outer half of the cortex is fed by the periosteum. And the periosteum generally leaves the cortex alive. It keeps it surviving in this disease. This is a bone marrow disease. But the internal, this is kind of that chalky, bony, dry rot material that I mentioned. Microscopically, all the bone cells are gone down here, up here, and most of them are gone in this condensing osteitis. And so I think this is just sort of a mini version of what goes on in the cortex. The very outer layer seems to be a little alive, so it's got a bit of translucency, the way normal bone looks when it's fresh. But the other has this white chalky look to it. And I think that's the end of, okay, this was another one that shows essentially normal bone. You see no discoloration, but there is this hollow space, and I don't know what to do with this. Arbitrarily, Bob McMahon has said any hole bigger than 0.5 mm is classifiable as osteonecrosis. That's published in Cranial. We don't know if that's just an arbitrary figure. How about all these small spaces? If you look in somebody with osteoporosis of the hip, most of them will have small spaces under half of a centimeter in size. And is that a disease or just sort of a phenomenon, a ischemic phenomenon? I have decided I'm going to be using the half a centimeter as my criteria. And if it's smaller than that, then I will put like a fudge diagnosis saying ischemic phenomenon, ischemic change, ischemic damage. And if it's larger, then I'll use the more formal diagnosis, osteonecrosis. But that's still arbitrary. This is not so uncommon to have otherwise normal bone with a little hollow space here and there.
Every one of these bridges that we've seen for edentulous.
They're older people, yeah.
Right, but why are they edentulous?
Oh, the comment was every one of these has been edentulous, and why are they edentulous? I think if I remember one study that I did with 226 patients, about a third of the patients were not edentulous, or the third of the cases were in people that had never had a tooth pulled in the area or any kind of work done in the area. I don't know if these people are edentulous because of pain. Maybe their teeth were pulled over a period of years, or whether it was periodontal disease. Maybe the infection from the periodontal disease was damaging the bone. I just don't have enough history on the autopsy cases.
I just come back to dander. I see so often that classical loss of teeth in the rear with the formaldehyde toxic patients, and upper front, the maxilla, the pesticides lay in that portion of the jaw, and the benzene in the lower portion of the jaw. And I see it in spades with these people that walk in my office. The carpet layers have lost their teeth in the formaldehyde area of the jaw. And you look at Bill Ray, and what does he say? The nervous system is destroyed by these chemicals. And here you have this incredibly innervated area. And I see it with DDT people, with the farm workers. They've lost, these teeth are all gone. I just wonder where the chicken is here and where the egg is.
Yeah, the question for those who couldn't hear it, or the comment was she sees a lot of people with various toxic occupational problems or situations, and formaldehyde was DDT, those are specifically mentioned. And her comment was that she thinks this might be causing neural damage that eventuates in bad bones, I guess. It is true that the bone has to be constantly stimulated by the nerves. I mean, this is a two-way street, and we don't know what comes first here. Two more questions.
Just go over the differences that you're aware of, the differences that you're aware of between trigeminal neuralgia type pain and the type of pain that's more characteristic with this.
Question is trigeminal neuralgia pain versus this pain. The typical pain of a NICO patient is this deep, often burning, intermittent, eventually constant pain or ache. They usually refer to it as a deep ache. And many patients have difficulty, in my experience, saying exactly where it is, where it stops and where it starts. And that's why and plus another characteristic is it changes over a period of weeks and months, not only in the location within a quadrant, but even bouncing between quadrants. That's a real problem with this textbook chapter that I mentioned early on. I'm supposed to come up with some kind of a classification system for pain, and it's so variable in this. You know, the trigeminal neuralgia pain is this sharp lightning blast or bolt pain, and some of that occurs in atypical facial neuralgia, but it isn't very constant and it's not very common. It usually is quite easy, the neurologists tell me, to diagnose trigeminal neuralgia, but atypical facial neuralgia or atypical facial pain they consider it like a garbage can term. It's when everything else is ruled out, that's what it is. And so it's probably a mixture of a whole bunch of different diseases. Okay, well, thank you for being patient with me.
Good job.
Yeah.
Thank you, sir. You're sweating there a little bit.
Yeah, well, it's
Working hard.
under the lights.
Where's your thing?
Claim happened 5 years ago. Well, I was a real small firm, and my GL policy, my occurrence-based policy, only had a 250 limit, and I'm sitting here today with huge assets and expecting this little policy to protect me from yesterday's claim. I don't think it's better or worse. I think it's more control both for the insured and the insurance company. Obviously, we know claims that happen and we can reserve them, and we have more control and knowledge about our IBNR, the incurred but not reported. Actually, for us, it's never incurred but not reported because they're always reported. It's incurred but not enough reserved, maybe. But that's the worst risk that we run into, as opposed to the GL claims or the occurrence-based policy. So that's where I go in that conversation. I think it was just, it was a control issue. Insurance would not have been offered to professions if it hadn't been done on a claims-made basis because of the magnitude and severity and the risk of those claims. They wanted to cover those claims that came up today. But I think we're picking up a huge risk in picking up people's prior acts. Mm-hmm. We have they can give us an application today that shows quality controls, internal peer review, this and that and the other thing. They might have implemented it 3 months ago. They may have just written that quality control manual. We don't know that they did 99% was residential work up until 2 years ago. And see, we don't capture that. Anything more than 2 years old, we're not even asking the question, right? So the risk in a claims made form, I think, is equal to the risk in an occurrence form. But they do function differently. But I think the claims made gives people more control of their own insurance related to their own assets.
Okay.
There is part 6 under the conditions, cancellation, page 10. Currently, we have been sending out letters 60 days ahead of time before renewal. Basically, it's a conditional renewal notice. Your policy is coming up for renewal. The rates or something else may change in that policy. Talk to your agent. What's happened is that letter has been going out at about the same time that you've been calling on your client, and they're getting confused. So we have discontinued that letter that was basically a conditional renewal notice. It's required in a few states, and we will do it by state endorsement where it's required. But we're going to eliminate that and just say that we will give you 60 days notice prior to expiration if we intend to not renew. Conditional renewal is something different. And so, because you're already involved in talking with your clients 60 days ahead of time, 90 days ahead of time. So what happens if you're 90 days up to your X date, you're out there talking to them, shaking hands, and all of us collecting an application, all of a sudden a letter comes in from the insurance company saying they might not have insurance, it might not be renewed. It sent the wrong message, and we realize that, so we're trying to correct that. We've stopped the letter, we're going to fix the policy so that we're not violating the policy, and we will do, there are 6 or 7 states that require conditional renewal notice, and we will put those on the policy in the future. The next page, page 11, and you can see on the right-hand side we have a liberalization clause. That is a mandatory endorsement, 37-211. Liberalization, I think I said before, means that if we enhance coverage, if we file and have approved any coverage